Welcome, everyone, to another segment of Montgomery Heart and Wellness Beyond the Script. And I'd like to get you started on our first of a three-part series on medication side effects. I want to go over the clinical overview on this first talk and give you some insight as to what it means to have medication side effects. We're going to talk about the definitions of medication side effects. And I want to also talk about the different factors that contribute to medication side effects. So this first talk is going to be a little bit technical. I'm going to give you a little bit of insight so that you have some understanding as to what medication side effects are. If you are a patient on a number of medications, or you have a loved one who's a patient on a number of medication, this will give you insight and hopefully will enable you to ask the right questions of your physicians regarding the medications and also regarding your overall health and what the medications may be how they may be benefiting you, or also how the medications may be causing some harm. And we in the medical field always have to make this decision on a regular basis. However, it's important to have the patient understand the potential side effects because you may be looking at the option of making a lifestyle change, as we often recommend patients do, versus taking a medication. Sometimes it seems easy to just take a medication as opposed to making a lifestyle change. However, if you know some of the side effects or potential adverse effects of these medications, you may think differently. So I want to empower you with some knowledge, and so we're going to get started. First of all, with the general definition of what is a medication side effect. Now, medication side effects, that phrase is a little bit more of a vernacular in medicine. In the medical literature, you'll see the phrase adverse drug reaction. So medication side effects are really medically referred to as adverse drug reaction. So we're going to use medication side effects. However, it is the same as an adverse drug reaction. So you may hear a physician talk about an adverse drug reaction, and medication side effects is the same thing. So what is a medication side effect? It's any unintended reaction to a drug that's administered in a customary dose by the right route for diagnosis and treatment. So what does that mean? If I give you a medication X at 5 milligrams, and say take drug X 5 milligrams once a day, and the purpose for drug X is to lower your blood pressure. However, after taking 1 or 2 doses of drug X, you get a rash or you break out in hives. Well, I didn't intend for you to break out in hives. I didn't intend for you to have a rash. So those are unintended reactions to drug X if you take the right dose. On the other scenario, if you were to take drug X, instead of taking 1 tablet at 5 milligrams daily, let's say you take, 15 milligrams or 3 or 4 doses of that drug. Well, that's a problem because that's not the intended dose. And so if you have a reaction to that, that's called an overdose, not a medication side effect. So we want to make sure we differentiate from the two. There are 2 basic groups of medication side effect. One is a clinical medication side effect. What that means is that there are no noticeable signs and or symptoms. This could be due to an allergic reaction. Allergic clinical side effects is due to the immune system. So for instance, the example I gave you earlier, if someone take drug X and you break out into hives, that's usually due to an allergic reaction. It's an immune mediated reaction. Rashes are often related to that. Sometimes people may have wheezing, their lips may swell. So these are reactions that are typically immune. Their allergic reaction is mediated by the immune system. However, there are other adverse reactions that are clinical. For instance, if you take something, you become dizzy or nauseated, or maybe it gives you diarrhea. So these are not necessarily through the immune system. So these are non-specific chemical reactions, and we often don't know the mechanism. So we would call them adverse reactions. So there are 2 basic medication side effects. There's an allergic, which is immune, or there's a general clinical adverse reaction that's non-specific. But the definition of clinical is that you feel the symptoms or you can detect the symptoms. There's another subcomponent, which is subclinical. Subclinical means that we cannot detect what's going on. You may have a reaction to a medication where For instance, you take a drug and it may have some effect on your liver. And you may take this drug over a long period of time and not know this having an effect on your liver. We can draw liver enzymes, they may be normal. You don't feel any pain, you don't have any swelling. And so you take this drug over a long period of time and you have a subclinical adverse reaction, but it doesn't manifest to sometime maybe years later. And I'm having an example of that down the road in one of our clinical presentations. So you have those two basic medication side effects. Now, what's the magnitude of this problem? Well, medication side effects cause over 100 deaths annually. Sometimes it can be 120 deaths. So it's quite sizable. It's greater than the seasonal flu usually, and it's probably greater than or equivalent to what we're projecting the COVID-19 deaths to be. They're projecting the deaths to be somewhere in the neighborhood of 100,000 this year. We don't know that for sure. It may be lower, it may be higher, but it's still somewhere on the order of the same number of deaths as medication side effects. It's only 17% of the cancer deaths on only 15% of the cardiovascular disease deaths. That's heart disease and stroke combined. So that puts it around third place as the leading cause of deaths with seasonal flu and maybe COVID if it's a yearly disease state coming close behind. So as I said, the third leading cause of death behind cardiovascular disease. It increases morbidity. So you have increase in hospitalization, increase in hospital length of stay. Here's some graphical data showing that the annual death rate of cardiovascular disease somewhere between 600,000 and 700,000, cancer being between 500,000 and 600,000. And there in third place, you see medication side effects, and your seasonal flu and possibly COVID-19 are probably even equal to that, or at the lower case, small fraction. These causes of death fluctuate each year as far as with the flu. I have S1N1. The swine flu is one example in 2009. COVID-19, we don't have all the data as the time of this recording, but in some worst case scenarios, we're expecting it could be as high as 100,000 deaths for the year. However, again, that's a comparison that you have. So what are the general factors? This is important because, it's one thing to say medication side effects are prevalent, and obviously the medication, the type of medication will certainly contribute to that. However, the age of the patient, the older patients are more susceptible to medication side effects, generally due to the fact that they're older. Their bodies are there's more wear and tear on their organs, the GI tract, the liver. Younger patients tend to be at greater risk for long-term subclinical reactions. So in other words, if you're starting a medication, maybe you're on medications for attention deficit disorder. These medications can have subclinical effects, and this could persist for a long period of time. For gender, women tend to be more susceptible. Women are smaller, so their metabolism may be different. They're not well represented in many of the drug trials, so we may not have the appropriate dosing for women when we come out with the recommendations for certain drugs, and so that may be a contributing factor as well. There are also genetic factors. Some ethnic groups metabolize things through the liver differently than others, so we have to keep these things in consideration. There are variations between racial and ethnic groups. There are differences within racial groups. There's a difference in dosing that may be required. We in our office started using pharmacogenetics at one point, where we got insight into the difference in a certain patient's ability to metabolize a drug through a certain enzyme pathway called the P450, cytochrome P450 enzyme cascade. And so it would tell us whether a medication or a certain enzyme pathway was very functional or whether it's very non-functional. And so I would literally be able to determine whether I can give this person the regular dosing of a certain drug versus a small dosing. Now, this testing was somewhat limited. It did not test every metabolic pathway, and so it was helpful, but it didn't give us the total picture. So you have to use judgment at the end of the day. And of course, body habits is important. The very large people, very obese individuals, have more problem than individuals who are very thin, but very thin individuals with a small body habitus may require lower dosing. So if they get the regular dose, they may be at risk for adverse side effects. I've had a number of patients where I would have to give a drug that was twice a day. They would take it only once a day because they would have excessive reactions to the drug, and it wouldn't be really an adverse reaction, but it was almost like an overdose. But again, let's say, for instance, I give them a medication that slows the heart rate down, but then it slows the heart rate down excessively at the regular dose. So then I would have to cut the dose in half. So by definition, it's an adverse or a medication side effect at the regular dose because it's an unintended reaction at the given dose. However, by simply cutting the dose, they tolerate the medication very well. So it's kind of a cross between an overdose and an adverse side effect, but technically it's an adverse side effect because it's an unintended reaction to a given dose. Even though I want to slow the heart rate down, I don't intend to slow it down too much. So some drugs I'd have to give a lower dose of what the intended prescribed dose is, or the standard prescribed dose, or standard recommended dose in that case. So that's kind of a scenario where you can say, well, the standard dose is too much. So in one sense, it's an overdosing. However, the standard dose is the intended dose. And so you get an unintended reaction to an intended dose or the recommended doses, then it's technically a medication side effect. But we simply treat that by decreasing the dose to a substandard dose. Now, what about social factors? Alcohol consumption. Many people drink socially. Most of our patients we see, when they come in, we do the review of systems. We ask about alcohol, and they say, well, I drink socially. I don't know what that means most of the time. However, sometimes some people social drinking is more than others. But either way, you have to keep this in mind because alcohol can have a contributing effect on whether you have adverse drug reactions. So if you're taking a certain drug that's metabolized in the liver, maybe that you may take this drug on a scheduled basis or on an as-needed basis. So for instance, individuals may get over-the-counter acetaminophen. So over-the-counter acetaminophen is metabolized through the liver. Let's say you've had a long work day on Friday and you have a little bit of a headache. You go get a couple of acetaminophen tablets and it relieves your headache. Then you decide you want to go and have happy hour with your friends, and so you have happy hour and you drink. You get a little too social, if you will, and then the next thing you know, you may be having some problems with your liver. And so keep in mind that alcohol is metabolized by the liver. If you're on a number of medications that are metabolized through the liver, then you have to be mindful of your alcohol consumption. You may even have to totally eliminate your alcohol consumption, especially if you're on multiple drugs that are metabolized by the liver. We have a large number of people with liver disease, either due to alcohol or that's not due to alcohol. However, many people don't consider themselves alcoholic, so they get what's called non-alcoholic, steatohepatic liver disease. And so it's actually non-alcoholic steatohepatitis or NASH. And this condition is problematic because we tend to attribute it to a number of things. Many people who are obese have fatty livers. Many people have multiple drugs, may have drug-induced liver dysfunction. However, these same individuals may be social drinkers, and their definition of social drinking may be a little bit liberal, where they may be consuming too much alcohol. So it's a mixed picture between alcohol, multiple drugs, and some of the chemicals that you get in the food. So alcohol consumption is a very, very significant problem potentially, and you have to keep this in mind. What about smoking? Smoking can also contribute to adverse medication effects or medication side effects. And so this is something that you really want to keep in mind when you are a smoker. First of all, smoking by itself is a problem. So if you're smoking, whether you're on medications or not, you need to work on quitting. But if you're smoking and you're taking medication, which is a high likelihood because the smoker tends to likely have high blood pressure, heart disease, or elevated cholesterol, then you really need to be mindful of the fact that it may contribute to the side effects. But what about people on multiple drugs. We have the medical term called polypharmacy. Polypharmacy, poly being multi, pharmacy being, pharmaceutical agents or drugs, is multiple drugs. And polypharmacy is probably one of the biggest problems that we see. This is multiple drugs due to multiple diseases. I mean, when I'm as a cardiologist, I see patients with congestive heart failure. I see patients with coronary disease who've had heart attacks. And these patients don't just come in with pure heart disease. I rarely see a patient come in and say, well, I have congestive heart failure and nothing else. No, they have congestive heart failure, diabetes, hyperlipidemia, they have arthritis. They may be on pills for gout, bladder incontinence, etc. And so they've seen multiple medications, multiple physicians by the time they've seen me, and they're on multiple drugs. And so polypharmacy is a big problem in their situation. What are some of the related issues? Well, if you're taking multiple drugs, you can sometimes overdose or underdose. You may have drug X that you have to take twice a day, drug Y you take 3 times a day, drug Z you take once a day, and you may take X once a day and Z 3 times a day in some matter of confusion. Sometimes drugs have names that are closely related. And so you can, polypharmacy puts you at increased risk of having confusion in terms of the dosing. I see patients that come in at 20 medications. I say, well, how in the world do you remember to take all of this? On top of that, there's data showing that there's an increased amount of dementia associated with taking multiple drugs. So just think, you're on 5, 6 different drugs, and you have different dosages. Some of the names are similar, and over time you're taking these medications, and your brain fog sets in, your memory starts to wear, and you start getting confused. So bullet point number 3 contributes to bullet point number 2, where you're taking the drugs too much in some cases and too little. And again, that contributes to other adverse side effects. Now, when you have one drug that can interact with the body, that's a drug, to body interaction or drug to person interaction. However, when I give you 2 drugs, there's 2 drugs to the body interaction, but there's also drug-drug interaction. So with one drug, that's 2 interactions, or at least 1 interaction going on. But when you add 2 drugs, there's 3 interactions going on. That's drug A interacting with drug B, and drug A interacting with your body, and drug B interacting with your body. So there are 3. As you add more and more drugs, the permutation of interactions go up. Drug A, B, and C goes up. So you have interaction between drug A in the body, drug B in the body, drug C in the body. Then there's interaction between drug A and drug B, drug A and drug C, then drug B and drug C. So you have all of these different interactions, and those interactions between A and B has another interaction with the body that's separate than A's independent interaction with the body and B's independent interaction with the body. And so different drugs have different metabolites, and as these drugs are broken down, metabolites of one drug may interact with the metabolite of the other. So as you can imagine, if we add more and more medications to the regimen, you're dealing with not only drug A, but drug A is broken down into 2, A1 and A2. These are metabolites. Metabolites is just a component of a drug when it's broken down. So when you consume a drug, it doesn't stay in its own biochemical component that stays as a biochemical makeup. The body interacts with that drug and breaks it up maybe into 2 or 3 different other components. One component may be absorbed, or one component may be eliminated. The other component may hang around for a while. And so you have these different drug components that are interacting with the body, or interacting with other drugs primarily, or interacting with other drug metabolites or breakdown components. So once we start to add more and more medication, you start to get what I often refer to as a biochemical soup, or I should say a chemistry soup within your body. And so you have all of these chemicals floating around doing who knows what, because we really don't have a firm idea as to how these drugs interact with the human body in every case. And an individual medication has its own list of side effects, which is often 100, 200, 1,000 different potential adverse reactions in some cases. And then it has interaction with other drugs. And so it's no way we can keep up with what these drug interactions are. So polypharmacy can be a particularly problematic issue. The other thing with polypharmacy, and even with single drug prescription, is that you get a paradoxical disease progression. What do I mean by that? Well, sometimes I may give you a medication that is supposed to, say, decrease your chest pain. It may increase your chest pain. We is well known with drugs that are antidepressants. They're given for depression, and they may cause more depression. Some antidepressants can cause predispose someone to suicide. Medications given for anxiety can cause more anxiety and the like. So these medications can cause a worsening of the problem that they're supposed to treat. I remember a study that was done back when I started my fellowship in cardiac electrophysiology, and it was a study looking at patients who had had heart attacks, and it used to be that they measure the arrhythmias in these patients after they've had a heart attack. And so they would then say, well, look, patients have more arrhythmias or an increased risk of sudden death. So what if we were to give them an antiarrhythmic drug, that's a drug that decreases arrhythmia, and see if it will improve their overall survival? So they did a study where individuals had heart attacks, and after heart attacks, if they had arrhythmias, then some drugs, some patients would be put on a placebo, and then one were given a class 1 antiarrhythmic medication. So they looked at the study, and they had to end the study early because these patients that were given the antiarrhythmic drug were dying faster than individuals given the placebo. And what they found out is the antiarrhythmic drug had a pro-arrhythmic effect, meaning that even though the drug was designed to decrease arrhythmias, they found that individuals taking the drug actually had worse arrhythmias on average, and they were dying due to arrhythmias and not being saved. And so that trial taught us a lot about antiarrhythmic drugs, and particularly class 1 antiarrhythmic drugs. So that's an example of a progression, a paradoxical progression, a progression of a disease that you're trying to actually suppress. So it's important to keep these things in mind with medications. Now, what are related factors? Well, heart disease, liver disease, kidney disease, and GI disease are all related factors. If the heart is not functioning normally, the flow of blood throughout the system, through the kidneys to the liver, is abnormal. So you can have multi-organ dysfunction, which will directly affect the body's ability to break down, metabolize, and eliminate a certain drug. So the heart function itself could cause a problem because it's affecting other organs directly or indirectly. Liver disease is very common, and it's a major problem with drug effects, adverse medication side effects, largely because many medications are broken down by the liver. So if these medications are broken down by the liver, and let's say you have liver disease due to alcoholism or some other cause, then you're not going to be able to tolerate the standard dose of medications, and you're going to be at increased risk of a medication side effect. In fact, the standard dose of a medication may cause you to have a coma, or have hypersomnolence, or even go into a coma for that matter, because people with liver disease have what's called hepatic encephalopathy. Hepatic meaning liver, encephalopathy meaning brain dysfunction. So they have a dysfunction of the brain related to liver disease. Why is that? When the liver is damaged, the liver is one of its major roles is to metabolize, to clean the blood up. So there's certain toxins that get into the blood. If you're on a standard American diet, there are chemicals that you may have consumed with the preservatives in the food. Animal protein itself, has a nitrous compound in which is consumed, gets converted to ammonia, has to be then broken down to urea by the liver. So by consuming animal protein, you may build up a lot of ammonia. If the liver doesn't function normally, you may have high levels of ammonia in the blood if the liver is not able to convert this ammonia into urea. So the urea is not as toxic, but the ammonia is. So someone with liver disease, by just simply eating a regular diet, will have a buildup in ammonia, and it may be subclinical. They may not be very groggy. However, if they take a Tylenol, acetaminophen rather, or take some other drug that's broken down by the liver, then the liver function will be further suppressed because it's then carrying on an extra load. So liver disease is a very important related factor that contributes to medication side effects. Similarly, kidney disease. There are many medications that I cannot give patients who have either advanced or end-stage kidney disease. Digoxin is one drug. Sotalol is another drug that's metabolized by the kidneys, and these drugs can't be given in somebody who has advanced kidney disease. GI disease is another problem. People that have poor motility, they don't absorb very well. These medications can be problematic to the GI tract and can be problematic if they have GI disease, if they're not going to absorb the medications very well. What comes to mind, certain diabetic pills, certain statin drugs can cause diarrhea. And also medications in general has an adverse effect on the gut microbiome. You know, our gut has to have healthy bacteria. That helps with digestion of food. It helps with our absorption of nutrients. And so this is very important. And if these gut bacteria are destroyed by the medications we're taking, then it's going to have an effect on our nutrition. It's going to have effect on our gut function. We may have a lot of bloating or gas or dyspepsia, which in some cases may lead to another prescription when in fact it may simply require a modification of the existing prescription drug. So there are many, many issues of related factors. I just gave you a few. Now, what are some of the subclinical adverse effects on the organ dysfunction? This is very important because, as I alluded to earlier, you have clinical reactions, which are noticeable signs or symptoms of a medication side effect. However, many individuals, and I would even argue perhaps most individuals, have what's called subclinical adverse reactions or subclinical medication side effects. And even if you have a clinical medication side effect, so let's say you're taking a statin drug and it causes a little bit of aching, you say, well, I can tolerate a little bit of aching and so I'll keep my cholesterol down and that's great. But that statin drug, in addition to the muscle ache that it may be causing some subclinical problems as well. And so the subclinical problems with the liver, perhaps, where the liver may be getting damaged slowly over time. It may have subclinical adverse effects on the brain. There's data showing that individuals on statin drugs can have sometimes violent behavior. There's some case reports on that. So there are a number of things that can be happening subclinically that then over time, after say a year, several years, you then get a clinical manifestation of this drug that you didn't get right away. So you can have subclinical adverse effects. The GI tract is another area where, again, I mentioned earlier, if you're destroying your microbiome, this can lead to chronic malabsorption. We have patients in our clinic that we measure their vitamin levels and mineral levels. We also look at their gut microbiome. And oftentimes we see many patients who are deficient across the board in vitamin C, vitamin B complex. They're deficient in magnesium and CoQ10. We say, well, what's going on? Well, these patients may have a decreased gut flora, which we also measure and find, in fact, the gut flora, the microbiome is unbalanced. And so we have to correct the microbiome. But why is that the case? In many cases, we're seeing individuals who are on multiple medications, and this is having an adverse effect on the GI tract. The kidneys is another one. There are medications that are metabolized by the kidneys. And oftentimes, you may not get an adverse reaction right away, but over time, you notice the kidney function slowly, progressively decline on medication. This could be over-the-counter medication, non-steroidal anti-inflammatory drugs, can cause this. These are just standard pain medications that people take for headaches and backaches and all sorts of ailments, and they take them on a regular basis, even though it's not scheduled. These can impair the kidneys, and if you're prescribed a medication, maybe a diuretic that's causing you to be dehydrated, these can have a combined adverse effect and affect the kidneys as well. The heart, we've had individuals taking medication. Some diabetic medications potentiates ischemia in the heart, so the coronary arteries don't function as well. There's some diabetic pills that contributes to heart failure. So we have to keep in mind that many medications that we're taking can have an adverse effect on different organs. How about the brain? Well, there are medications that do cross the blood-brain barrier and have an adverse effect. I'm going to give you a discussion on a patient that had an adverse effect to medication on the brain. In the clinic, it looked like it was a clinical adverse effect. But I think there was a subclinical component because on one of the medications that I'll discuss with you, he had been taking it for a while. So it probably had been building up in his system to where then it manifests as to some neurological problems. And there are many other potential adverse effects, many that we know or don't know, skin changes with some medications. Some medication may affect the adrenal glands. Some medication may affect the thyroid glands in ways that we don't fully know. So keep in mind that when you're taking medications, there can be adverse effects on the organs. The doctors, we work hard to monitor the organ system. We draw blood, we monitor you clinically, but also you need to be mindful of what you're consuming, what you're putting in your system. If you're on a lot of prescription medications, get with your doctor and discuss possibilities of weaning them. Maybe some medication can be consolidated. Maybe there's some lifestyle change that you can make, and we'll discuss some of those things in the third talk that can reduce your need for medication and reduce the potential side effects. So my final thoughts are the following. Medication side effects is a major problem. It's the third leading cause of death. And it's something that we really shouldn't mess around with. It's something that we should be mindful of in terms of how it affects our lives, how it affects us overall. It's something that we need to take seriously. If you're taking multiple medications, get with your doctor and find out how you can maybe wean those medications. Find out what lifestyle changes you can make that may improve your health without the need for medications. So this is an important thing. The third leading cause of death are the medications that we prescribe. So again, keep that in mind, and let's all try to get healthy together. So until next time, the best of your health. We're going to sign off here at Beyond the Script. Thank you for your attention, and I look forward to visiting with you the next time.